a very important topic of polycystic ovarian syndrome and various issues in terms of diagnosis and management in adolescents. So today what we are trying to do is to just summarize that again, and Dr. Proteek will go through the adolescent guidelines which are there. These guidelines are basically available through the most of the freely available on the net, and they are based upon consensus sort of a statement. They are not, I would say, as much evidence based, and still we have to understand that there is a huge discrepancy about in terms of what is PCOS, how to manage, how to follow up. So they talk about diagnosis of PCOS in a great extent, and this is something which we'll see what the guidelines say.
Good morning. This is basically a quick recap of the class we had earlier, and it is an international consortium update regarding polycystic ovarian syndrome. Now, I've divided my presentation into introduction, pathophysiology, diagnosis, and treatment. We'll go through the initial part quickly. Of course, introduction, it is a complex heterogeneous familial disorder which consists of hyperandrogenism and chronic ovulation. So both are not independent. They should have both of them, not just androgen or just ovulation. Pathophysiology, it has been discussed. It is a combination of multiple genetic, neuroendocrine, metabolism, and defects in steroidogenesis, ovarian, all. It's a combination of everything. Now, primary ovarian pathophysiology is basically the hindered dynamic balance between growing and dormant follicles. There is an increase in AMH and increased LH levels, increased intra-ovarian androgens. There is increased growth of small follicles that have all been discussed earlier. And of course, a genetic predisposition of DN and the A1A, V2 gene, and there are higher ketotestosterone levels also being found. Insulin resistance is a common finding. It is independent of the degree, now this we need to know, it is independent of the degree of adiposity. So it might be present in less adipose patients. It is independent of body fat topography. And one very important is that it is tissue selective. So it is in ovary, you will find decreased resistance, but increased resistance in skeletal muscle, etc. will be there.
So basically what I'm trying to say is that 50% of them are obese.
Yes.
So a PCOS patient against a normal patient will be more likely to be obese. Even if they have same BMI, they will have more likely to have a central adiposity. Even if they have the same level of central adiposity, they will be more insulin resistant. So they are one above high in that perspective. And as you very nicely said, that there is a first hit which has already happened. So PCOS cannot be acquired. It cannot be thrust upon you. You have born with PCOS, and then you have some changes which can do that.
Now, what insulin does is actually increases LH levels, decreases the SHBG levels, stimulate P450-17 and side chain cleavage. It also increases the gonadotrope sensitivity to GnRs. So at a pituitary level, hypothalamic level, it is also active. And also it increases the aldoketoreductase, ultimately leading to increased androgens. Now, obesity alone is associated with insulin resistance and compensatory hyperinsulinemia. Now, what we need to understand in this patient, in these cases, it is the ectopic fat accumulation, meaning where fat is not supposed to deposit, is where more deposition. Same sort of thing happens in SGA children. So, hence, they are also at increased risk of insulin resistance. Now coming to what they are focused on, they have said that the diagnostic criteria is divided into required criteria, optional criteria which is not required. So, in irregular menses and oligomenorrhea is required definitely. And hypoandrogenism, they have mentioned 2A and 2B. So, clinical as well as biochemical, they have mentioned here. PCOM
morphology.
Okay. The PCOM, which is the PCO morphology, is an optional criteria. It is not like if you have it is diagnostic. And severe cystic acne, not mild acne or moderate acne, which is improved by medication. More than 10 and dark comedones, white comedones formation, which is not responsive to treatment as well. Now, what is important is obesity disease is not required. It is good to search for. I mean, it is an association. It is good to search for insulin resistance, but it is not diagnostic. And biomarkers, I will be speaking about them later. Now, important is this here some comments about this. The irregular menses should be present 2 years after the menarche. So 2 years, and it may go up to 5 years as well post menarche. And we need to rule out other disorders such as NCCH and Cushing's syndrome.
So if you just stop there, so basically, if you look at all these confusing pictures, what they talk about, if you go with what Professor Rosenfield has said, how he defines PCOS in adolescents is very simple. It is unexplained hyperandrogenism of ovarian origin, which is persistent. So if it is very, very clear now. So it is unexplained, so you have ruled out all those causes. It is of ovarian origin, so all those things will come up, and it will be persistent beyond 2 years. So if you look at these three things, unexplained, ovarian, persistent, these will really, and hyperandrogenism, this will take up to PCOS very, very clearly. So in this, they have tried to do very important PCO morphology. Last time we discussed huge is of no role. The only role is whether this somebody who is at risk of PCOS will have a chance of persistent PCOS later. This is what PCOM may tell you, but nothing else.
Coming to hormonal irregularities, what is important, this should not be used as the only criteria in PCOS in adolescents. It may persist after 2 years post-menarche. It includes oligomenorrhea, which is cycles more than 45 days. Secondary amenorrhea means 3 months of amenorrhea after normal cycles. And dysfunctional uterine bleeding means cycles less than 21 days or lasting more than 7 days, bleeding lasting. Now, hyperandrogenism can be divided into clinical, that is most importantly hirsutism. Should be excessive coarse terminal hair, and most common, this is
very, very important. So you look at their body hair otherwise, like yesterday we discussed that case. If it is like the same, it is not hirsutism.
Mild can be significant only if it is associated with menstrual irregularity. So FGS less than 15. So
and focal hirsutism is something which is also only if there is an ovulation.
Acne, as I mentioned, moderate to severe inflammatory acne, especially if unresponsive to topical therapy. And premature adenarche, as well, pubic hair before the age of 8 years, may lead to PCOS. So these patients we need to keep on a lookout and rule out NCCH as well as Cushing's syndrome. Biochemical, now they've mentioned that it is important in symptomatic adolescents before making definitive diagnosis. So they are saying you do a total or a free testosterone. If you're using LCMS, then more than 42, they mention cutoff. If you're using radioactive amino acid, it is 55. However, there is no clear cutoff, and they're accepting that it's not mentioned. Imaging, again, the PCOM criteria, that is increased stroma, peripheral, small cysts. This was initially done in adults, and transvaginal route was used to bring out the morphological criteria. However, adolescents, it is not reliable. And in what is more reliable is the ovarian volume. Initially, it was 10 ml, and now it is increased to 12 ml, which is suggestive. Now, biomarkers. Initially, it was mentioned that high levels of AMH correlate to small follicles. Higher the AMH, it is more towards PCOS. But it is not. There's a very weak association in adolescents. So adolescents should not be used AMH. TDHT ratio, again, the study they've used mean age of patients 35 years. So we cannot use what criteria they are using. They have not mentioned in adolescents. SCD40 and HSP, these are all immunological studies. This is done in Bahrain, women SCD40L. However, for clinical criteria, it is not mentioned any cutoffs. Insulin resistance and compensatory hyperinsulinemia are not considered to be diagnostic criteria. Again, they've given a certain number of criteria such as FGIR, fasting is to glucose to insulin ratio. Again, what they are mentioning is growth hormones treated patients, and in these patients, less than 7 was taken as insulin resistance. The HOMA-IR with more than 2.5, Matsuda and HD criteria, again, highly studies based. So it is not, clinical criteria is not given properly. So again, we can go by acanthosis, etc., and we can see clinically there's insulin resistance. Now coming to treatment, they have mentioned baseline treatment is always lifestyle modifications first, local therapy for hirsutism. They have mentioned additive pharmaceuticals, not mentioning you have to start. Additive pharmaceuticals include metformin and other pills which I will be discussing, and other concepts such as ovulation, contraception, and transition into adulthood. So baseline, always weight loss and increased physical exercises. It decreases testosterone levels, it raises SHBG levels, even normalizes menstrual irregularities. However, they have mentioned that in extremely obese, they often respond poorly, maybe due to social criteria and other criteria. However, no large RCT supports benefits of exclusive weight loss in normal weight PCOS. The normal weight, they have not mentioned any improvement due to exercise. Local therapies, of course, if it is very severe, photoepilation is suggested. Waxing, shaving, etc. is mentioned, but somehow due to if you want a more permanent response, so photoepilation by laser. And topical eflornithine, as we had mentioned, it is a ODC, ornithine inhibitor. So basically, it is an adjuvant to photoepilation, and it is in laser-resistant facial hirsutism. But these are all later, and when you have a very severe hirsutism. Before that, we can try other cosmetic therapies. And topical finasteride DHT inhibitor is not recommended. Now, metformin. One very important fact I would like to tell that there is no FDA-approved medication for PCOS. However, there are several RCTs which have been done, and metformin is the only insulin sensitizer that has been evaluated by RCTs. It improves postprandial as well as fasting blood sugar. They have mentioned you started with 850 mg per day, and you go up to maximum 1 gram. They have not mentioned higher than 1 gram dosage per day. And of course, we know it causes GI discomfort as well as lactic acidosis. Now, this is one important point. In this study, in this article, they are mentioning the use of metformin in either obese or overweight or non-obese but who have insulin resistance. So, in two criteria, you should use metformin. Either you are an obese patient or you have signs of insulin resistance, only then you use metformin. So, meta-analysis of metformin versus OCP showed that metformin and OCP had similar benefits of hirsutism, triglycerides, etc.
This is something which you have to take with a pinch of salt. See, if you look clinically, you won't be giving just metformin. So if you just give metformin, I don't see how much hirsutism will come down. It's mainly the amount of weight you lose is what is there. So OCs become very, very important because most of them will have anovulation. When we say anovulation, is a part of criteria. So metformin is like an additive. So you start OCs with lifestyle modification, then you decide about metformin, eflornithine, or you talk about antiandrogens as a second line. So head to head, nobody will give metformin alone just to PCOS because unless you have type 2 diabetes or something like that in those situations.
Antiandrogens, such as ARBs, spironolactone, which is the most commonly used. We start at 25 mg per day and go up to 200 mg per day. Flutamide, it is highly bad.
Never use spironolactone without OCs. These are only after OCs.
Third generation progestins, such as cyproterone acetate. Now, cyproterone acetate can be used as a separate drug, which is 50 to 100 mg along with estradiol estradiol, or they come in combination in such as dian and 2 mg combinations. It causes liver toxicity, but very rarely we have seen, and 5-alpha reductase inhibitor, finasteride, etc. can be used, but as very important, it needs to feminization of male fetuses, so that needs to
I have not seen much response with finasteride as discussed last time. If you look at theoretical perspective, the major effect of estrogen on the whole cycle is via the SHBG level and progesterone a bit by inhibition of LH. Now, people talk about cyproterone being better and doxycycline being better because they will cause less weight gain, this will cause more antiandrogen. But if you look at actual evidence, any pill may be good enough in that situation.
That antiandrogens significantly reduce the hirsutism as compared to placebo. And of course, efficiency is enhanced when you combine OCP, metformin, and antiandrogens, which is the triple combination which they mentioned. The OCPs, you can either use estradiol, estradiol. I mean, it is usually a combination OCP, that is E and progesterone combination component. Now, the issue is what they mentioned in their study, no specific formulation can be used because when they did a specific, they combined information of 6 RCTs. They saw that the ethinyl estradiol with the cyproterone acetate, it did bring down the symptoms but increased the triglyceride levels as well. So they are not suggesting or telling anything, but they think it can be used.
And there comes the role of metformin. If you add metformin also, that will try to mitigate the adverse effects of some of these progesterone preparations and estrogen preparations.
So they have in the end mentioned that the combination therapy of metformin, pioglitazone and spironolactone of course, with OCPs leads to normalization.
They are saying without OCPs.
That's what.
So this is one. There was one trial of this in which they used these three. I think maybe the authors of that trial may be part of this guideline committee, but nobody uses
this
combination. Pioglitazone we won't be using because it's more of weight gain. And so what they're saying is that if you use this triple therapy, that time there was a lot of these polypharmacy going on, like you combine ACE inhibitors with statins, with aspirin. So you had ramitorva, polytorva, so a lot of these things were coming. So that was the same line. So you give one pill which contains metformin, pioglitazone and spironolactone and be happy on that. But I don't think this has any sort of a role. But because the same people are writing these guidelines, they have mentioned this is a very good thing. There's one study probably says that maybe having positive effects but not causing this cardiovascular risk, then that part. So,
without OCP.
Without OCP. But how can you use spironolactone without OCPs? If somebody becomes has a period and has a pregnancy, there will be a huge problem of feminization. So this is theoretically okay, but nobody would be using that perspective.
Reproductive aspects, what they mention is that 10% of all PCOS can have normal ovulatory and they can go ahead to become pregnant. They can use, of course, OCPs are being used, so that is the best sort of contraception, but sometimes they use progesterone only pills or progesterone rings, but of course OCPs are much better. And the aims in adolescent should be that to basically to reduce the visceral obesity, reduce the central fat, improve the ovulation, and reduce the complications such as that gestational complications such as preeclampsia, preterm delivery, etc. should be aimed at adolescents. So summarizing, initially irregular menses with hyperandrogenism, according to this study, saying clinical as well as biochemical requirements. Biomarkers are not validated adolescents. Insulin resistance is not a diagnostic criteria but helpful association. Combined weight loss and physical exercise are the first line therapy in overweight and obese girls. No pharmacological therapy has been approved by FDA or EMA for use. No high quality RCPO specific OC formulation has been told by this study. And they are suggesting triple low dose combination for insulin and antiandrogen components.
So I think if we go by these guidelines, they provide us good framework in terms of pathophysiology. They've done a lot of work on pathophysiology, which has been very well presented. In terms of evaluation, they've said very clear that PCOM is not something which is required. So you need hyperandrogenism with an ovulation. But as far as management, they are still not very clear because we are not very clear about what management is. It has to be individualized. So if you have an obese girl, more with an ovulation, not much of menstrual irregularity, maybe metformin. Obese girl with menstrual irregularity along with hirsutism, OCs, very significant hirsutism, we would start OCs with spironolactone. You can't say, okay, 6 months we will wait and then 6 months again. So these are all the things you have to think of in that perspective. So it has to be individualized. We need to have more protocol based, but it sets us a good guide in that perspective of how to evaluate and manage PCOS.